Good morning, everyone. Happy Friday. Um, Thank you for joining us early on this Friday morning. Chilly 1st of May. We are going to get started. We know that some will trickle in, but we thought we would get started because everyone has put in such good effort to arrive early today. So, welcome. I'm Dr. Becky Ray. As you know, I am a family doctor in Port Perry and the regional primary care lead for the Central East Regional Cancer Program. And thank you to our fabulous team at the Central East Regional Cancer Program for arranging this webinar this morning. We're really lucky this morning to have two fabulous speakers joining us. We have Dr. Christian Murray joining us. Dr. Murray is a graduate of McGill, Dalhousie, and the University of Toronto, as well as UBC, where he did his surgery fellowship in Mohs micrographic surgery, or his derm fellowship in Mohs micrographic surgery. He is an associate professor of medicine at the University of Toronto. And Dr. Murray teaches at the Dermatology Center at Women's College Hospital and the Carleton Skin Clinic, and serves as program director for all dermatology fellowships across the university. He's a frequent lecturer and publishes regularly in journals and textbooks, and he is also on the Cancer Care Ontario Guidelines Committee for Skin Cancers. Dr. Murray is a founding member of the Canadian Association of Mohs Surgeons, a past president of the Canadian Society for Dermatologic Surgery, and the director of the American College of Mohs Surgery Accredited Fellowship at the University of Toronto. So we super appreciate you being here today, Dr. Murray, to join us and provide us with the talk today. Also joining Dr. Murray is Dr. Roxana, I'm going to get this right for you, Roxana, Miti Teltu. And Dr. Miti Teltu is a dual board certified dermatologist in Canada and the United States, and a fellowship trained Mohs micrographic surgeon as well. She completed her dermatology training at McGill University and her fellowship at the University of Toronto, and is a member of the American College of Mohs Surgery and the executive of the Ontario Medical Association Dermatology section. Her practice focuses on cutaneous oncology, Mohs surgery, and cosmetic dermatology, with expertise in non-melanoma skin cancers and facial reconstruction. And she practices at the Carleton Skin Clinic in Toronto. So thank you both for joining us, and I'm going to pass it on to you guys.
Thank you. Great. Thank you very much, Becky. I really appreciate it. I'm gonna do some of the first bit of the lecture, and I think Roxana's gonna save me if my voice fails, or if there's more knowledge than I have than is needed. So let's go on to the next couple of slides. I think are more formal things. Yeah, that is us. I don't have any relationships or financial disclosures. Roxana mentioned that she's done some stuff with L'Oreal, but that will not have any relationship to today, and there's no conflicts that we can think of. Same. Our goals are really to talk about skin cancer, when you should be concerned, when to refer, what to do if you don't have the ability to refer quickly, and we'll test our knowledge about some common things and uncommon things related to what's normal or abnormal in the skin. We understand that there's a variety of people on the call today, and we're going to save lots of time at the end for questions. But if there's something really burning, you can stop us. It's pretty informal, although I'm used to these things in person, but stop us with whatever way you want, and we can review the topic. Thanks, Roxana. So in terms of skin cancer, there are many types. So really anything that exists, any cell type that exists in your skin can become malignant: hair follicles, fat, connective tissue. But really the main things, that the big three, are basal cell carcinoma, squamous cell carcinoma, and melanoma. So that's what we really focus on. There are many other types of skin cancers that are much more uncommon, but they're so uncommon that we don't really bring them up as much. So we'll focus on the main three today. Why should you care about it? Well, first of all, it's extremely common. I'll explain how common it is. It causes morbidity in patients, even mortality in some patients, and it's expensive to the healthcare system. And all of us are in a great position to help. Most of us are in primary care. meaning we're first contact with the patient in many cases. And so we're first to identify and recognize and therefore catch this disease at an early stage. So you're in a great position to help recognize and start the ball rolling in terms of getting them the best management. This is an awful case that I saw when I was at the hospital, and a person who was in a long-term care home, and they said, well, he's just sleeping on his pillow and it's rubbing against the back of his head, and that's why he has this sore. But no, this is a large skin cancer invading the bone. And the next slide will show you that you can see that even on his neck there, on his right sort of clavicle, there's a lymph node there. So this person has metastatic squamous cell disease, and people thought it was almost like a bed sore in this unfortunate man who died from this disease. So the next slide will show you a more common situation in which there's an area there on the cheek. It just didn't feel right. It was bleeding when he rubbed it against the shower, and how big is this thing? Well, we're not really sure. The cheek has never been normal, and we started doing surgery. You can really see the next slide will show you how big it really was. Large amount of the cheek was involved in this basal cell carcinoma. So although it can look dramatic in the first case, and you knew something was really wrong when the next case you weren't really sure. So it can be a bit occult. Next slide. I think this may have been one of your cases, Roxana, that you put in, but this is an example of something that it's a little freckle, or is it a melanoma? So that's the difference between something that is don't worry about it, this is just you're born with it, versus deadly. So it's really important to recognize these things and catch them. Next slide is great. Talked about common. It's the most common cancer worldwide. So these are some Canadian stats. And when I say Canadian stats, you got to take it with a grain of salt, because it's so common that it's basal cell and squamous cell are so common, they don't even capture how many they have. It's too difficult for Cancer Care Ontario and all the cancer regional areas across the country to catch them. So they really just estimate them with point studies. So melanoma we know about, because those are all sent in when there's a pathology of melanoma. It all goes to Cancer Care Ontario for stats, but basal cell and squamous cell are so common that they just estimate them. And you can see that although it rarely causes death, basal cell carcinoma is over 100,000 cases a year, squamous cell about a third or a quarter of that, but does result in more deaths. The others are less common, as I said, but we see them all the time. Next slide. In terms of all cancers, you'll see that non-melanoma skin cancer it's almost the equivalent to all other cancers combined. So although many of them are easy to treat, easy to deal with, it's just so common that recognizing it and treating it is very important. Slide. I mentioned about a third of all cancers in Canada, maybe more. If you're a baby born in 1994, these are just stats. It doesn't mean you exactly, but of course, but is a chance every third person will get non-melanoma skin cancer. So extremely common. And because of people are living longer, maybe it's because of more ability to get in the sun, this cancer's incidence seems to be increasing faster than any other cancer. And it costs billions of Canadian dollars every year, and trillions in the United States. Next slide. Who gets it? Well, you can see what I look like. I'm the kind of person that gets it. So I'm an older white guy. It doesn't actually matter whether I'm a man or a woman, but so the lighter the skin you have, light eyes, fair skin, if you have a family history, sure. Older, over 40, most of the cases, but you can get them under 40. UV exposure. It's often as a child. People in their 70s come and say, "Oh, but I've been using sunscreen the past couple of years." I don't ever like to use the phrase "the horse is out of the barn," but I'm thinking it, because a lot of the sun exposure you had as a kid lasts your whole life. So if you live somewhere tropical, it's worse. If you did tanning booths, it's worse. If you worked outside, it's worse. But really, all of us generally get enough sun exposure to put us in the realm of getting skin cancer. If you're immunosuppressed, that is the immune system that goes around and looks for cancerous cells and removes them from our body. So if you're suppressed, it can't do that. So they have a much, much higher chance of getting skin cancer. We don't know exactly the fine details. If they're on prednisone, does that mean that enough, or they need to be on really strong immunosuppression? I think the greater the immunosuppression, the more likely it is that they're going to be really predisposed to skin cancer. So, for example, someone who's a kidney transplantation, they get a little bit of suppression. Someone has heart transplantation, they get a lot of suppression, and we can see they have much more skin cancers in the heart group versus the kidney group. Other exposures are relevant, whether they've had radiation as a kid, HPV and arsenic, but the top two are the big ones. So it's not a quiz, but it just shows you. The next slide, I slipped this in, Roxana. You can see, okay. So in the green jumper is a cousin of my daughter's. And then my daughter's standing there with her friend. Who has the highest risk of skin cancer, my daughter or her friend? I don't know if there's a way to vote on this, but you can think about it. And the answer is my daughter's friend has the highest risk of skin cancer, not my daughter, because she's the one, my daughter's the one in white. So anyway, next slide. So UV light, it is a complete carcinogen, just like smoking. So it can initiate cancer, but also promote its growth. So it mutates the cells, but also suppresses immunity. That is, the light does that. So it starts the ball rolling with the UV mutations all in the skin, and then it lowers the body's ability to recognize those. We think that basal cell and melanoma are more related to episodic, that is short bursts, or typically thought of as sunburns in kids, whereas squamous cell is lifelong exposure. That's what we think. It's very hard to do this kind of research because no one's gonna, it's decades and decades later. So it's really epidemiology. And then one of the ways that I think about this is they did some studies to look at kids who lived in Finland and then moved to Australia, and kids that lived in Australia and moved to Finland. Really, if you lived in Australia up till age 8 and then moved to Finland, you for your whole life had Australia rates of skin cancer. So it didn't save you once you got to Finland later. Whereas the opposite is true. If you're in Finland and moved to Australia as a young age, you kept your Finland rates. So we think that the younger age is really the sweet spot for causing cancer in most of these cases. Next slide. What are the precursors for actinic keratosis? Sun-exposed areas, one or many scaly plaques. So it's often areas where you get a lot of sun exposure. You have these scaly areas. It usually starts off as normal skin, and then it's almost dryish kind of skin. Then these individual dry lesions, and we'll see examples of that clinically. And then you get these thicker areas. So we can talk about how to treat that, because there's a difference between treating and preventing. So prevention is when your skin is pretty much normal, and then the treatment is the treating even the precursors like actinic keratosis. So we'll talk about how you can destroy it. You can use certain creams to raise the immune system. Remember, I explained how if your immune system's lower, you can't fight off these precancers or cancerous cells. So if we raise the immune system, maybe that'll help the immune system itself get rid of them. That's great, except that it's very annoying to use these creams. And things that destroy it with light-based or laser-like treatments. Next slide. So here's an example of a gentleman who has, when you look over the whole forehead, you see it just doesn't look right. There's these scaly plaques all over. Some of them have red around them. Some of them are just scaly. It's sometimes difficult to determine what is just dry skin, what is seborrheic keratosis, what is actinic keratosis, and it's not easy. And I have difficulty sometimes, but usually if there's red around them, that's a tip off for me to suggest the body's trying to do something to it, or it's being irritated or inflamed. And these are pretty typical examples of actinic keratosis, because they're stuck on. You can you rub them a bit, and it can even be a little bit tender sometimes. But these are examples of actinic keratoses, and they're often widespread like this in sun-exposed areas. You'll see it on the back of the hands, whereas you won't see it on the forearm, that kind of thing. Next slide. Here's a similar example of the back of the hands. These individual scaly, often whitish or scale, not so much brown scale, and with some red around it is very common. Next slide. Similarly on the lips, we call this actinic cheilitis, but it's really the same exact process. This example is sometimes difficult to tell between, again, dry skin. In some cases, it can almost look, if it's individualized, like a cold sore if it's a focal area, but it's the scaly or very dry skin that happens. They can often bleed. It's generally not the upper lip. It's not impossible, but generally not the upper lip, and usually the lower lip. And that's just because of the way the sun hits us as it's coming down. It hits the lower lip, not so much the upper lip. Next slide. All right. So let's talk about the clinical presentation, as I mentioned. Basal cell and squamous cell. The most common thing that I hear is, I was getting out of the shower and I rubbed a towel and it started to bleed. That is what I hear every single day. Or I thought it was a pimple, but it never really healed. I'm just mentioning this because this is they can tell different stories, but that's a tip to me. You think, okay, it's the exact same thing. And then there's often a long story associated with, the cat scratched me or did I bumped it, all these kind of things that are completely irrelevant. But it's important to realize that a lesion that bleeds should really tip you off. It doesn't mean it is skin cancer, but it's quite common. So non-healing skin color papule, or they call it pimple. Basal cell often slow growing. Squamous cell can be slow growing, but it's often faster. And most of them are on the head and neck. You can get them other places, but this is where the money really is. For melanoma, totally different story. It's going to be the brown spot. So many people, when they think skin cancer, that is patients especially, they're thinking about the brown because there's been a much bigger campaign about melanoma. Well, I thought it had to be a brown spot or a regular mole. That is often true for melanoma, but the more common types, basal cell and squamous cell, present as skin colored, whereas melanoma is this irregular, pigmented, usually brown, changing lesion over time. Many clinical subtypes within each, but let's go through a few things here. So basal cell, I mentioned the pimple-like skin color papule. It's often pearly, so when you stretch the skin out a bit, you can see a whitish area to it. Has these little blood vessels in it typically. Ulceration in the center is common. That's why you often see a little bit of bleeding. So it's just breaking down, expanding like an ulcer, like an erosion going outwards. It can be brown. It can be scar-like. It can almost look like that you had a chickenpox scar, that kind of a scar. Or it can be very superficial and scaly and flat, like an actinic keratosis, and we have a difficulty telling the difference between these. So it can be a lot of different presentations. And here's one of those. This, if you see that little central little thing in the middle, that's the ulcer I was talking about. You can see the little red lines in the middle. That represents the little blood vessels. And when you stretch this, it looks whiter than the normal skin. This is what I call a pearly papule on the upper left lip. All right, let's go next. She's trying to get fancy maybe with a pointer. I don't know. Here's an example of a sclerosing, which just means scarring. You can see the white around it. All that white stuff is still basal cell. It's not where the basal cell is sort of broken down the skin and moved on. You do a biopsy and where she's put the arrow there, and you can clearly see basal cell infiltrative cells all through that. So this is a good example for clinically, because you can see the actual basal cell. But if you just saw the white, people get confused. Oh, I had this scar. I've had it for years. It just seems to be growing. Scars generally don't grow, right? So something's up there, and that needs a biopsy. Next example. This is a superficial one I was talking about. You could be thinking, and you see this. Well, could this be fungal? Could this be psoriasis? Could this be actinic keratosis? Yes, it could be all those things. But when you really look closely on this, and if we were able to look right into it, often the edge has that pearliness, or there's some features in it. Maybe there's some white areas in it with scarring, which you shouldn't see with fungal disease. There's some scale that's a little bit thicker, it can bleed. Little things that tip us off the diagnosis, but it's not always easy to make. Next slide. Again, this looks like more of a superficial one. I get, almost, you could fool me and say that you had some sort of a dermatitis there. And, with a quick glance, I could easily think that. But when you look closely, you'll see some of the other features. Next slide. Here's one that has multiple features. I think the top end of this looks like a regular basal cell, similar to the one on the lip. The bottom end has some brown in it. So, you'd be thinking, oh, what's making the brown? Could this be some sort of a weird melanoma, nodular melanoma? Could this be pigmented basal cell? Those would be the two things that I'd be worried about. And some of the features look really pearly in this, so I'd be really strongly favoring the basal cell carcinoma. But I bet you this is bleeding, all those sort of same features. It needs a biopsy. Similar example of pigmented. This almost looks like a pigmented version of one of those superficial ones. In the middle is probably a regular, that is invasive basal cell, whereas the edge has got this pearly, but it's got brown in it. So pigmented basal cell would be this diagnosis. Thanks. I'm going to leave this to you, Roxana. You're the expert. dermoscopist?
Yes. So dermoscopy is a very useful bedside tool. You use a dermatoscope, which lets you magnify times 10, and it just gives you another clinical clue. Like often you still will need to biopsy, but what you're looking for basal cell carcinoma is these blue-gray globules, or sometimes it's called like nests. So let's see the pointer here. The other things you're looking for is what is described as leaf-like areas. Sorry, there's a typo there, but they're these same nest features, but they kind of form a leaf-like structure. The original papers use very descriptive terms, so you'll see terminology like leaf-like, spoke wheel, and then the other feature on dermoscopy, which is quite subtle, but once you see it, you'll start noticing it more often, are called May globules. So that stands for multiple aggregated yellow-white globules. So you see kind of this reflection here of these whitish yellowish. And these are a sign of basal cell. It has a very high sensitivity and specificity in the 90%, and are also suggested that it's going to be a deep basal cell. The vessels you can clinically see, so as Dr. Murray mentioned, you can just see it with your eyes, but with the dermatoscope, it lets you see a bit closer. And the vessels in basal cell are arborizing, meaning they branch off. So you see like a blood vessel here, and they'll have tiny little branches off. And this is helpful to distinguish from other entities like sebaceous hyperplasia, which has a different vessel distribution. Next is squamous cell. No, Dr.
Oh, thanks.
Murray.
Yeah, sure. I was just going to say for some people in the audience, and I don't know your level of comfort with dermoscopy. Many of you are like, "What is she talking about?" And I'm closer to you than I am to her, just to let you know. So it's a skill. It's something you need to practice. It's this little handheld thing which magnifies onto the skin. She and I were at a meeting on the weekend, Dermoscopy Canada, in which I am not a good at dermoscopy. She is. It's a skill you need to learn and hone over time. Anyone can learn it if you're interested in it. So if you are interested in that, you should reach out to someone. There are courses if you're interested. It's not just for skin cancer. It can, moles and benign things. It's really useful tool, and we don't all have that innately. So if that was all Greek to you, then don't worry about it. So squamous cell carcinoma. This is we talked a little bit about the sun exposed area, the lower lip, the ears, dorsal hands. Those are the big areas, just like actinic keratosis. It's the same risks of sun exposure, but more of a long-term risk, so lifelong exposure rather than episodic burns. HPV is often implicated, especially in genital areas. Radiation, immunocompromise. It's often scaly, and it can spread. So this is unlike basal cell, which grows in one area, but it can grow involving large areas, as you'll see in some of the slides coming forward. But squamous cell doesn't need to be that big and can spread to the lymph nodes and cause death. Next slide. Here is an example of it's pretty typical. I would look at this and probably think this is a thin squamous cell. So more on the surface, looks very scaly, almost warty. Next slide. This is a really example, really thick. The scale probably grew pretty quickly in this person, and it really looks like a wart or a nodule that has grown quickly and is super scaly. The scale really makes me think more squamous cell than basal cell. Basal cell can be scaly, we saw that, but squamous cell, that's one of the key features of squamous cell. Next slide. This is more of a nodular area. There is scale to the right side of what I'm looking at, but there's a nodular component. So when I see a lot of scale, I'm thinking, one of this could be more squam than basal cell. And if they tell me, it's more tender. Squamous cell often is pressing against nerves more likely than basal cell. It's more rapid growing than basal cell. This is what leans me towards the squamous cell angle. Next slide. And this would be a subtype of squamous cell, meaning it's so rapidly growing. Keratoacanthoma is the subtype of it. It grows very quickly, and for some reason, which I don't understand, and I don't know if anyone understands, it can even resolve on its own. Maybe it triggers the immune system to fight it off very quickly, and it can break down. The problem is we don't know which one are going to be keratoacanthoma versus squamous cell. So we rarely say, oh, it grew really quickly and it looks like a keratoacanthoma. Let's just leave it, because there have been many situations where they left it and left it and left it, and it caused death. So the ulceration in the middle of this, you can see it's almost like a volcano. So it's got this central area of necrosis, which is volcano-like, the rapid growth. That really makes us think keratoacanthoma. Next slide. I'll leave it to you.
Yeah, the dermoscopy of keratoacanthoma is again like an adjunct to your clinical diagnosis. So you could see the same volcano crater form keratinization. So that's like that scale in the middle. And then I find the hair vessel, the hairpin vessel. So that's describing these vessels here that are supposed to look like hairpins. That's very suggestive of a keratoacanthoma. And then this is to contrast to a squamous cell carcinoma. The vessels there are described as glomerular. So they kind of look like the glomeruli of the kidney. And of course, like this, I find squamous cell actually more challenging to diagnose with dermoscopy, but I do think it's a helpful adjunct tool that you could learn. So now, Dr. Marino, if you want to speak about the outcomes.
Thank you. Can you hear me okay?
Yes.
Okay, great, because I'm in my car. Could you put the back? Actually, do you mind speaking for a second while I get the
Yeah.
slides hooked up? Thank you.
Yeah. So outcomes. So most non-melanoma skin cancer basal cell squamous cells have very good outcomes. They're very treatable, but it really depends on the subtype and clinical factors of the patients if they're high-risk patients. So that's really related to the tumor and the host. The basal cells can invade local structure, but that is over years and very rarely can lead to metastases and death. The really important factor that I think we can all play a role in is that 33 to 77% of patients will get another basal cell in 3 years after the initial diagnosis. So I think it's a great opportunity to screen these patients and counsel them. For squamous cell, they can sometimes be more aggressive. They can invade locally, and they can also rarely metastasize, and there can be death from metastasis. And once there is a metastasis, there's a 34% 5-year survival rate. So they can be more aggressive.
Just to add in there, one of the things that happens, people often say when we treat these skin cancers, well, how likely is it to come back? And I'll usually give them two different numbers. That is, well, this lesion is actually clear, so we have about a 98 to 99% cure rate if we're doing Mohs, for example. But you have now, the patient, almost a 50% chance of getting another one in the next 5 years. And they say, and that's a bit confusing. What do you mean? I thought you cleared it. Well, what we mean is that because we now know that you're the kind of person that gets these, or you're at risk for this, you're likely to get other spots. And this is just a point I'm making because people often think in cancer, oh, it's clear, I'm done now. Not really. You've identified yourself as someone at risk, so you're someone who probably needs to be screened or checked or followed for this reason. Thanks. So what are the poor prognostic factor for non-melanoma skin cancer? It's really the same for both basal cell and squamous cell, and it just makes sense. Skin cancers that are larger in tricky areas, if they have aggressive histology, that is, and there are so many types that are sclerosing, infiltrative, micronodular, previous incomplete removal. So people have tried before and they couldn't get it. Those are the ones that do poorly, and people are immunosuppressed. Not only are people immunosuppressed more likely to have recurrences for what you've just treated them, but also get new ones because their immune system's lower and they can't recognize them anyway. Next slide. Prevention. This is a complicated talk. Actually, I mean, a lot of this talk could be done in individually. I could spend a whole time on dermoscopy, a whole time on on histology, but prevention is one of those things that's a little bit confusing because there's I don't want to say lay press, but people have their own ideas about prevention. There have been studies looking at how effective sunscreen is, and I know there are many different types of sunscreen, but I try, just because it's simpler for me to think about this, to keep it as simple as possible. So in my mind, if you can prevent sunburns and prevent strong exposure to the sun in any way, that's the most effective thing. So I think sunscreen has a role, but I think in terms of priorities, it's down the list. So if someone's going on a week vacation, then sunscreen would be their last line of defense. The first lines would be avoiding laying out in the sun for most of the time, wearing hats, long clothing if they can, long sleeve clothing if they can, those sorts of things. Sunscreen is the last level of defense. I say that because when people like to talk about, oh, should I use a 40, should I use a 50, should I use a 30, should I use a 65, I'm using L'Oreal, I'm using all these different products, I really stop them and say, it really, sure, whatever you like. It doesn't really matter. You got to do the other things first in order to reduce the sun's exposure on your skin, especially those high risk areas. And then sunscreen can use to mop up anything that gets through. But I don't use that as armor in protecting you. It's the last thing. I think hats are much, much better. So we can talk more about prevention later, but let's go on. Like any cancer, recognizing it earlier allows you to pick it up at its early stage and treat it before it becomes dangerous. And if you don't, meaning it's either very, very high risk or it's spread elsewhere, you need imaging and sentinel node biopsy and even chemotherapy if it's spread. And there's some new things coming along, just like all the cancers, a lot of immunotherapies that are really promising and have changed the game for many of these skin cancers. Next slide. And so when you're looking at treatment, what are the key things you want to do? Well, first of all, you want to destroy the tumor. That's where we are now. Perhaps in 10 years, we'll be talking about preventing it at the gene level, but right now we're still barbarically destroying the tumor. So here are a lot of the ways you can do that. And next slide will show you that the top four the top four really destroy it sort of, I don't want to say willy-nilly, but they don't tell you that all the cancer is removed. So you can use cold spray, which really causes frostbite in the skin, photodynamic therapy, which targets some of the sun-damaged skin and sort of blasts it. You can use scraping or creams if it's very thin cancer. Same with electrodesiccation. It's sort of scraping it with almost like an ice cream scooper to get rid of some of the cancer. But and those things are all very helpful for very superficial or shallow disease. So if you know it's that, meaning you've done a biopsy to show it's superficial, or you're very good clinically and you can tell, I don't think this is deep. But if it's deeper, you're very likely to miss it with doing some of these methods because they only go so deep. So you need to go either to radiation, excision, or Mohs surgery, which is a variation of excision. Next slide. Again, when you're talking about the ideal disease, if it's a superficial, shallow, easy disease, really any of those methods would probably work. But if you're thinking about something a little deeper, a little more aggressive, you need to be sure the cancer cells are removed. And the only way to really do that is to confirm it pathologically. You, of course, want to spare injury to normal tissue to allow for proper function and cosmesis. Next slide. And that's really what Roxanne and I do is Mohs surgery. So this is a procedure that was developed to specifically target skin cancer, meaning detecting in real time, you're removing the cancer, but also testing the margins. So that allows you to, when you're doing a regular excision, you sort of have to pick the margins. Well, go 5 millimeters, 6 millimeters, because you really don't know. You're guessing. And so you're hoping that the margin that you're taking is going to be enough. Instead, what we do is we take a very, very thin margin because we're not really worried if we miss it at the right side or at 12 o'clock, we'll go back to 12 o'clock. We'll take a little more. So we can start off really small and trace it out. Next. Here's an example of someone that I don't know if you were guessing with a wide margin what you would do. This is a guy who had excision and then radiation, and he's got the scar, and he had a little bit of bleeding inside of his nose. So people were going to say, well, why don't you just excise that skin cancer in his nose? And if you did that, you'd be wrong. Next slide. You can see a little bit of bleeding inside his nose. Like, where do you start there? Looks like it's going to be a disaster, because it was a disaster. It went all the way in his nasal canal and onto the cheek. This is us tracing it out over many hours to try to find all the last cells. If you don't get every cell in this case, it's going to come back. Next slide. Deep. This is someone who had electrodesiccation before, and it looked like a scar there. It's really hard to tell where it is when it's been treated before. The cells can sort of penetrate and go under the scar tissue. They can hide in different areas. When we use Mohs, you can see the next slide, it was larger than we thought. Kept going a little wider. So we're not making it bigger because we want to. We're tracing out the cells in this case, and it takes a little while to do that, but we're tracing out the cells to make sure that we get all of them. Next slide. Sorry, Roxana. So the second one, so that was talking about one of the situations in which the cancer is bigger than you think. But what if the cancer is smaller than you think? You don't want to take a big piece. You'd like to keep it as small as possible. Next slide. Example on the nose, you can see this small little dimple. It was biopsied as a basal cell, but how big do you go? Next slide. You can see that if you're going to do a standard margin, that's the red circle, you'd have to go a little wider. And although it's not that big and it could be closed, this is someone's nose. It's important to them. And so we want to keep it as small as possible. Instead, we were able to start small and trace it out and keep it really small. See, a very small defect, cancer-free, and next slide will show you that we just sewed it together very easily. So these little differences, a millimeter here, a millimeter there, make a big difference in patient's quality of life. Next slide. Similarly, in tricky areas, you can see that the corner of the eye here, small basal cell was recognized. The red mark was what the margins would have to go around, and these are important areas. Are you affecting the lacrimal ducts? Are you affecting the ability of the eyelid to move? Next slide. Instead, we could keep it small, right? We were able to do smaller than what was expected and put a small graft or even let it heal secondarily. So we avoided hitting those functional structures. Another case, how big is this? No idea. I wouldn't want to guess. The more I do this, the less likely I am the less comfortable I am guessing how big it's going to be. So this is a guy who had radiation before, and now he's got this brown or almost grayish papule. You'll see the next slide. No idea. I would have no idea it would be that large. So this is an example. This is the kind of guy who would be back and back and back and back on of radiation. Instead, we were able to use it surgically. Thanks, Roxana. Next slide. This is sort of an example of a guy with a squamous cell on the back of his hand. How wide do you go? How deep do you go? We all know there are important structures at the depth, so you don't want to take too much, but you don't want to miss it. If it's wrapping around tendons, that's important to know. Instead, we were able, next slide will show you that we're able to remove it and spare, this is just how big and disgusting that tumor squamous cell was. We were able to spare all the important functional structures by getting a clear margin at the depth. This is the most important, and put a skin graft on. Next. Another example of a lady's neck. This was what she described as a many-year history of a scar there. Maybe she scratched it on something. Maybe she injured it somehow. None of that I don't think was relevant. This was a dermatofibrosarcoma, and you can see it's quite large when we remove it out with Mohs. End up being a lot of theories. But actually, although we can see muscles and bone and lots of important things that we can name, none of these were negatively affected. So we we were able to provide clear margins without huge bony removal or important muscular removal in this case. And it was sewn up primarily, so she did very, very well. This is all under local anesthetic. All the cases that I'm going to show are. All right, off to you.
So now let's move on to melanoma. And often when we're looking at moles, we want to rule out melanoma. And that's because earlier on, we can have irregular nevi that can look clinically like melanoma. So the important part here is that only a minority of melanoma come from a nevus. So about 25% of melanomas arise in a pre-existing mole. Most melanomas are actually new moles. So always listen to your patients if they say they have a new lesion that's growing or changing. Patients who get a lot of irregular nevi are also at risk of having a high risk of getting a melanoma. And irregular moles are often defined by the ABCDEs, which we're quite familiar with. Irregular nevi or dysplastic nevi are, as I mentioned, just very difficult to clinically distinguish, and even the pathologists have trouble distinguishing them. Their prevalence in the population is at 2 to 18%, and they make up about 15 to 20% of melanoma patients. Most patients will develop their moles by the age of 20, but you can develop a mole at any time. I do in my clinical practice, I do find if somebody says they have a new mole after the age of 30, that's just my clinical cutoff. I always make sure to pay close attention to it. We don't need to excise irregular nevi, but some which we are very suspicious if they're changing, we should biopsy to rule out, as I mentioned, melanoma. So this is an irregular mole. And why this is very challenging is that some patients have many dysplastic or irregular nevi. And I think this is challenging for myself too to follow. And my clinical tip for you is just to try to take photographs, ask the patient to take photographs. You should also, if you can, upload photographs to your EMR because doing regular serial photographs can help you try to distinguish which moles are changing. The other thing that I find is useful is to look for the ugly duckling sign. So there's a concept that we have a signature nevi. So we all make moles a certain way. But if we have one that is an ugly duckling, so different than the rest, we should pay closer attention to that one. This is another young patient that has many moles, so you want to closely follow those patients. So melanoma, as we know, can be deadly if not caught early, though luckily there's many advances now with immunotherapy, which is changing survival for patients. And once we diagnose it, most of the treatment is often surgical, and the margins are dependent on the Breslow depth, so the depth of the melanoma. There are four major subtypes: the superficial spreading, nodular, acral, and lentigo maligna. So this is superficial spreading. This is the most common subtype. And this is another example. And I just want to just quickly show you that dermoscopy could also be useful for diagnosing these. The same, I find like when you're first starting dermoscopy, you can think of the same A, B, C, D, E rules that you're using clinically. So is there an asymmetric border? With a dermatoscope, you can just look more closely at the border and see if there's asymmetry. You look for streaks at the periphery. So you can see here that the pigment is going to the periphery, and that's a sign of melanoma. This is an example of a nodular melanoma. These tend to be more aggressive because when they're nodular, it means there could be more depth to it. And on dermoscopy, you could also appreciate that. So you have ulceration here and a blue-white veil. So that's this blue-whitish color. And that's also a sign that the pigment, the melanocytes, are deeper. This is an acral melanoma, which tends to also have poor survival. And this is also a lentigo maligna, so a very challenging scenario because many patients have solar lentigos, and distinguish them from lentigo maligna can be difficult. What you can use dermoscopy here again to help you is to look for these gray rhomboidal structures. So usually you have these follicular openings on the face, and in lentigo maligna, you have obliteration. So basically the follicles you can no longer see because the pigment is covering them. This is another example of a lentigo maligna, and they happen in sun-exposed areas, so particularly the head and neck. This is a very advanced case of melanoma. So we can, for the sake of time, probably get to the quiz.
Yep. Becky, do we think that we want to do open up to questions now, or we have some case examples? We didn't know how it would go, so.
Yeah, that's great. Let's do, why don't we open it up to questions, and then we'll see how we do for time.
Great.
So in the chat, I can see that there's a question from Dr. Catherine Berube. Is it safe for family medicine, like for a family doc, to biopsy a pigmented lesion to rule out a melanoma? So are there concerns about cancer seeding with a punch biopsy, or should we be referring these patients for a complete excisional biopsy?
I think it's very important to biopsy. So if you feel comfortable to do a biopsy, I would definitely urge you to do it. The risk of seeding for melanoma hasn't ever been proven in a study. I don't know if Dr. Murphy, you've ever found a study to say that. So I think it's totally safe to do. I recommend, especially if you're more novice, to probably do a punch biopsy because, as we mentioned, depth is the most important aspect for staging melanoma. So you want to make sure you ideally are taking an accurate sample. Um, and interestingly, I did read a paper from Ontario that showed that not having a biopsy delayed treatment for patients, at least by 3 months. So if that's your limiting factor, I urge you to biopsy if you feel comfortable.
I totally agree, Roxana. There have been studies to show that it does not negatively affect care at all. Do your best. The deeper the biopsy, the better. And it's very important. Do not worry about CD. Making the diagnosis is critical. That's a good question.
And if anyone has any questions, just put your hand up, and we'll call on you to ask your question, because we want to be able to answer as many questions as we can. From Dr. Boardman, how useful are private pay serial photographic screening programs for skin cancer detection?
So these are like the photo finder and mole scanning. I haven't seen any prospective data that it changes outcomes for patients. But I think they're like they make sense, and from a patient perspective, it's nice to have these images, especially it's very hard to like image your own back and image your feet. But I think you could, the patient could just try to take photos themselves. I don't think there's been studies that's changed outcomes for patients.
Yeah, I think it's it's one of those things that, as dermatologists, we don't know how to recommend these things because there's a lot of marketing, there's money to be made, and that's not a bad thing necessarily. It can lead to good things, but it does mean that some people who really have no risk are getting a lot of these things done. People with type 5 and type 6 skin are getting the body scan because they heard it was a good idea. I think some people need to have their skin checked. And if they can't have it checked by someone, whether it's a family doctor, nurse practitioner, or dermatologist, if they can't have their skin checked at all, then that's when these things have really found their way into people's lives. Secondly, so I think the people that is someone who has an understanding of nevi looking at the skin is better. As a second tier, these things may be helpful, especially if they're going to trigger people to think about getting their skin checked, or if there's these ugly ducklings these computer systems can pick up. AI is also changing the landscape quite a bit. Right now, it's but it's going to be good, and I bet you in a few years it's going to be better than all of us. So I think that it may have a part to play in recognizing skin cancers in the future. But currently, if you said which is better, to have your family doctor check your skin or have a photo finder, I would say family doctor check. Someone asked about congenital nevi. I saw that in there. That's what a big topic that is. How do you feel about that? I think of it as three main groups. There's the big ones. So congenital nevi are moles, that is brown spots typically that you've had it from birth. So really large ones, middle-sized ones, and small ones. The small ones really don't increase your risk of melanoma in that area. It does kind of tell me when people have lots of moles, even if they're normal, that they're more likely to get melanoma in other areas. So they need to be checked. It just tells you the kind of person. Large nevi, I think that those definitely do have a higher chance of melanoma. But the way I look at it is that they just need to be checked. So if you have a large congenital nevi, I've seen them on their whole face, half their back, these kind of things. They're not removing all of them is not easy to do. So we generally follow them and look for changes, but it's challenging. Those are the kind of people that need to be checked. I think. Don't you think, Roxana? They need to be referred.
Yeah, exactly. I agree with you 100%. So the size really matters. If they're small, we know their melanoma risk is actually the same as the general population or very close to. So we don't recommend to remove it. And then larger ones, are higher risk, and we do need to follow those really closely. And it's very challenging. You're really palpating the lesion, feeling for any new nodularity, but they do need close follow-up.
Great, thank you. There's a question. I'm just going to get over to the chat there. Do you have recommendations on how to punch lesions concerning for possible melanoma? I.e. punch size, where in the lesion is best to take it? Do you have to capture the edge of the lesion, or are you better going right in the center?
Roxana?
Yeah, so and I think it's you ideally want to remove the whole lesion, and obviously that depends on your comfort level on doing punch biopsies and the size of the lesion. If it's small and you can fit it in a punch, that's amazing. I think you should do that. If it's a really big lesion and you don't feel comfortable, I recommend doing a punch biopsy of the most suspicious area, so something more in the middle, ideally not necessarily the periphery. Also, you could do multiple punch biopsies. That would be my recommendation.
The deeper, the bigger, the better, and especially if there's the darkest area in the mole. Don't worry about capturing the normal skin because pathologists will know normal skin. In this kind of situation, that's fine. Someone asked about what dermatoscope to buy, Roxana.
I think it's like a whole marketing because the dermatoscope is actually just a very like a polarized light. But I guess I used the DL200 when I first started. So I think that's a good place to start.
Is it a big difference between the best one, the Cadillac, and the Datsun? Not
No,
a
I
major
don't think
myself.
it's a no, it's just like honestly, it's a light, but a magnified light. I think they're really expensive. So I wouldn't buy the most expensive for sure.
The more time you spent, the more experience you get. That's the more important thing, rather than the device.
Exactly. And really try to do clinical pathologic correlation. You don't even need a dermatoscope to do that. What that means is like you clinically thought it was a melanoma, your biopsy came back as a benign nevus. Try to think about like what were the features that may have led to that pathology result so you can also learn yourself.
Photos would really help that too. If you're anything like me, I'll forget the case an hour later. Whereas if you have the photo, oh yeah, this was the lesion. Oh, that was basal cell. Okay, photos really help trigger a memory in these situations when you get the path
Mhm.
back.
Perfect. There's a question uh, from Agnes Okonyuska. And Agnes, I might have you chime in, just turn your mic on to ask your question, just to clarify it. So I think the
I
question
think
is
I got
around,
it.
oh,
I think I
perfect.
got
Okay,
it.
that's
If
awesome.
you have one
Yep,
melanoma, are you likely to get others? Yeah. What do you think the stats are? Yes is the answer to that question. Again, same with the basal cells. Recurrence with the original melanoma versus getting a new one. The answer is yes for both. What do you know the numbers on that? If you have one melanoma, with a chance of getting another one is, Roxana?
I I I would have to double check, but I think around the 10%, but I'd have to double check. I can email you guys.
Yeah, also, to be honest with you, ChatGPT would help you with that. But the bottom line is their risk goes way up. So we don't only follow them because this one can recur. We follow them to look for new ones because the recurrence would happen in the skin, usually locally or in the lymph nodes and that kind of thing, whereas new ones would happen in the prone areas. That's why we examine their whole skin. It's a good question. Yeah.
And
What about a
they
course, Roxanne? Course
oh,
for
of course.
dermoscopy?
So just to finish with the reoccurrence, we know they also get all non-melanoma skin cancer. So you're not only looking for melanoma once they have had a melanoma, but also for squamous or basal cell, right? You're looking for any sun-induced skin cancer. So I think it's a great opportunity to screen these patients early. For a dermoscopy course, there's the Dermoscopy Canada. It's started by family doctors, and they have a not intro course every year. So you could just look up Dermoscopy Canada and you can find their course online. I think it's great to have a hands-on course, and it's in Toronto, so sort of close.
Yeah, good question next about, sorry, I'm taking over your role, Becky. I'm looking at the I'm looking at the chat too,
perfect.
because I know we're pressed for time. The antioxidants, a really good question. I actually like, so Heliocare, it's niacinamide or nicotinamide, they're the same and not the same as niacin. So when I write it down for patients, say not niacin. It's specific. There is pretty good evidence now that taking orally, this is a B3 type supplement, I'm going to call it, because it's over the counter. You get on Amazon. I usually give them a handout with where to get it, this kind of thing.
So I think it has been shown to reduce skin cancers, and it's really interesting. A lot of derm, it's not really gotten huge uptake, meaning everyone. It's not like in everyone's lobby. Definitely take it. Definitely take it. I think dermatologists are a little bit skeptical because the results were so overwhelming. But I do think that in people who are high risk, I talk to them about it. I think it's pretty benign thing to do. It's inexpensive, and I do think it reduces in some studies, as high as 50% less likely chance of getting basal cell or squamous cell. But other studies show about a 10% reduction. So I think it is worthwhile to do. And if people who want to do something, this is something that may reduce sun damage, actinic keratosis, but also basal cell and squamous cell. We're doing a study at the university now, looking at in transplant patients, because those people get so many skin cancers. The evidence would suggest it's not as effective in them, but we're doing a randomized controlled trial to look at that. So yes, I think it's effective. I'm a little bit suspicious of how much the literature has suggested it works, but I think it's something to consider. Yes. Darker skin, challenges with visual detection and monitoring. Roxanne, what do you think? It's
I just
absolutely
think
true.
it's true. I just think it's underdiagnosed is my clinical feeling about it because basal cell is still the most common skin cancer in all skin types. It's just that we often delay the diagnosis because it's not the top of our mind. So I think just to remain clinically suspicious if a lesion's growing, bleeding, it's the same risk factors. And just on exam, they do tend to be more pigmented. So more pigmented basal cells, you can have even pigmented squamous cell. And then for melanoma, acrolentigenous, more common.
Yeah, question about accessibility. Northern Ontario without a derm within 4 hours. Yearly exams for most of my melanoma patients sent to derm. Unsure how accurately track changes in those widely distributed. Yeah, you're in a tough spot. I completely agree. What would you suggest, Roxana, for people who very hard to get to see people in those situations?
I think this is when photographs are your best friend. So ideally, you and having the patient also buy into taking photographs. I think they also need to take ownership over their moles. So themselves taking photographs and doing self skin exams, I think will be important to work together in a collaboration with you and the patient. But I do think it's very challenging.
One of the things that may incentivize people to do video calls is we've got a new fee code in dermatology that we worked hard for with follow-up for high risk skin cancer patients. Brand new, April the 1st. So it is a little bit of a higher fee within dermatology to follow these people who have these high risk factors. So I'm just saying that may incentivize some people to get on teledermatology and that kind of thing, which is not perfect, but it's better than nothing in some of these patients. So maybe I'm hoping that we can incentivize that, which is the reason why we put this fee forward. What should be included to make an effective referral? I think for us in in the skin cancer realm, it's really why you think it doesn't need to be detailed. Is it lesion, cheek, looks like basal cell? And then instead of a long description of why that is, a photo. It doesn't need to be you taking the photo if you were the referring person. Just the patient's contact information is there. Usually what we will do as a clinic, we will reach out to the patient to take some photos because photos are so much better than any descriptions. So location, size, why you may think it is, bleeding papule cheek. That's all I really need to know. And then a photo. So I don't think it needs to be much detail. Do you agree, Roxana, or are there more features that are really critical?
No, that's it. And then I guess if it's rapidly growing, it helps to know that so we can triage it too.
Good point. Good. Or if you're thinking melanoma, we think a little different, or squamous cell, we're thinking a little bit differently. But I think our triage system is pretty good. So at the Carleton Clinic, I go through the referrals. A bunch of us go through the referrals. I'm going through them in a few days, looking at them myself, and also we get them in within a month or two. So melanoma, squamous, something urgent, we get them in a lot faster. But our wait times are a lot less than what you're describing Northern Ontario. So, of course, we accept people. I have people flying in from Thunder Bay all the time and various places. But yeah, we really are working hard to make our wait times lower. And if you're worried, you know what, I don't want to do the biopsies, we'll do the biopsies.
Perfect. I think we've got, yeah.
That's kind
I
comment.
totally agree. You know what? Thank you both of you for joining us so early on a Friday morning. I know you're starting a very busy clinic at 8 a.m. So we do want to let you get to that and not have patients waiting. But this was absolutely fabulous. And you could see from all of the questions too, just really engaging. So thank you, thank you, thank you for joining us.
Can I put a plug in there, Becky? Becky,
Yeah.
We had there were a lot more slides. Roxana had slides about how to do biopsies, videos, and this kind of stuff. It's a lot of stuff. Maybe we can come back, next year or whenever it is. We're doing a workshop at our office in a couple months for some family doctors with a specialty in dermatology. So we're really hoping to engage with the community more. We understand the challenges people have, and we want to try to provide tools for family doctors, nurse practitioners, anyone who's the frontline person to get these people seen and treated more quickly. So we're happy to engage on this front in little hands-on sessions, and we're really excited to be invested in everyone else's education too.
And I also put my email there, and I can help pass the question on if it's for Dr. Murray or myself. But if you want to come to the workshop or any other questions, or you want to see my videos of the biopsy techniques.
Amazing. Thank you. We'll definitely take you up on having you back, and we'll share all of the resources to everyone who attended following the talk.
Thanks very much, Becky. And thanks
Have
to
a
everyone
fabulous
for
day.
spending the morning with us.
Thank you.
Thanks, you too.
Amazing.
Bye now.
Thanks, guys.